microphone? Yes, it's on, isn't it? I don't usually have to talk very loud. But I will. Okay, well, some of you remember who I am. I kind of bebop in and out, but my name is Kathy, and I'm the clinical coordinator, plus I do all your medical physicals. So if you don't remember my face, I'm sure you remember my emails. So I'm here to talk today about therapeutic communication. Just a couple things. Angie knows you all by now, probably. She's really good at that. But I can't take attendance that way. Just check you off, make sure everybody's here. So I'm just going to send it around. Just sign your name. Make sure you sign it before the end of our time together. The other thing is, as I'm sending in your OPIDs and all that stuff for your clinical coming up soon, I do not have, if people work for Ohio Health, I need you to sign in, just put your name on here, what facility you work at. Shift isn't as important, so you can tell me that or not, but then if you have an OPID where you work, it's going to be different than your student OPID, but I need to know that work OPID because I have to put it in the spreadsheet. So I will send this around as well. I'll send it the other direction for now. Make sure you sign this before you leave today. If you work at Ohio Health. If you don't work at Ohio Health, I don't need to know where you work. Okay. All right. So, any other announcements? Anything you want to say before we get started?
Good job yesterday.
Yeah, it was. It was a good test.
So proud of you guys.
Yep.
And your check box work. So very good.
Yeah, I did check offs yesterday, and we did okay. Okay. Yes. Well, it was the first one. I know people were nervous, so trying to remember red rules and all that. You were nervous, so we'll give you a break this time, but probably not next time. Get it right. All right, so we're going to talk about therapeutic communication. And therapeutic communication is one of the most primary things that you need to have as a nurse. It's not going to matter where you work. It's not going to matter who you talk to. You should have therapeutic communication. And does everybody feel like at this point, I usually take hands, how many of you feel like you communicate therapeutically? Okay, leave your hands up. Now, would you say you communicate therapeutically all the time? No. See, so we all have work to do, correct? I've been doing this, been teaching therapeutic communication for, nearly 20 years. And I still will at times have a conversation with somebody, and by nonverbals or by what they subjectively tell back to me, it's like, I could have done that differently or said that differently. Think about when you have a fight or an argument with your partner or your spouse. Do you ever sit back and go, I really could have said that differently, and maybe we wouldn't have had the same reaction? Okay, that's really good if you're doing that because you're looking at it and evaluating and saying, maybe I should have said this. So hopefully by today when you leave, you will have some tips that maybe you weren't aware of, or tips that will help you to communicate better and more therapeutically. We're also going to talk about the nurse-patient relationship, because you guys have to walk into a room and very quickly gain the trust of that patient that you're working with, so that they will allow you to give them a bath or allow you to put a Foley catheter in something invasive. And nursing is the top trusting, career. So if they trust you, they're going to give you more information. You're also going to build a trust and build a relationship. So by the time they leave, it's not that you're sad necessarily that they're gone, but they feel like they were listened to, that you advocated for them as a nurse. So those are some of the things that we're going to learn today. So let's use this little vignette, and it's from your book. I didn't make it up. I just pulled it from your book, because if you're not reading these in your book, you can use these to gather information and figure out how a test question might be. So let's look at this. We have Randolph. He's middle-aged. He's diagnosed with end-stage liver failure, and he's being cared for in an intensive care unit, which is ICU. He's been comatose for several weeks. He has numerous tubes and drainage devices in place and is receiving multiple therapies. So that would be things like potentially occupational therapy, physical therapy, a lot of different therapies that require continuous electronic monitoring. So he's on a monitor, he's probably on a vent because he's comatose. He has all of these, probably has multiple IVs, drainages, so he's got a Foley catheter probably. So get a picture of Randolph laying in the bed in the intensive care unit. Because what we want to answer is, he's comatose. How do I communicate with Randolph? Anybody have an idea? Yes, ma'am.
Possible touch.
Touch, okay.
He sounds like he can still talk to him.
What's that?
He said, I think he can still speak. to
We can speak, and we don't know that he's hearing or not, but they do say that the last sense to go is hearing. So we're gonna talk to him. What else? Did somebody have something else, or were you just tagging on what she was saying? Okay, so how are we gonna communicate with him? Some ways, though, that when we do speak, we do want to be very simple. Okay, we're not gonna give him directions because we don't know that he can follow them, okay? But when we talk to him, we want the statements to be very simple. We want them to be real clear and that he can understand. When you communicate with somebody, you should do those things anyway. Simple, clear, and be able to understand. So when we look at auditory, visual, and kinesthetic, so got that picture of Randolph laying in the bed, you're the nurse, you're taking care of him, okay? So the spoken words, that's our auditory. Are we gonna talk loud to him? Why not? It might bother him. He's sick, you know, and when patients are sick, we want the environment to be restful, right? And quiet if at all possible. That's why we can close the doors, and usually in intensive care unit, you close the doors, they're clear, you can see through and see the patient, but the patient gets a quiet environment, and he's comatose, okay? So, and how we say those simple, clear, and understanding words. You know, are you gonna go immediately when we walk in the room? A lot of times nurses just go straight to the computer and start typing. And so the computer's over here and my patient's over there. So I'm talking because I want the patient to know what I'm doing, but I'm not talking to the patient. We're on our computer, you know, and even if we have a patient who can talk back to us, we're in the computer going, you know, doing assessment, putting things in there. When do we look at our patient?
all the time.
We should. We should ask our patient a question and look at them, and then if we want to do it in our computer, and then go back and look at them. That disturbs me a lot when I go, no matter where I go, and people are just doing stuff and talking to me or not talking to me, and I'm the customer. Happens at Walmart, okay? Go in there, they're on the computer in the pharmacy, talk to me. I'm the customer, okay? So remember that. Your spoken words, how loud they are, how slow they are, how fast they are. We're going to talk more about that as we go along. And then visually, when we go in, we should be visually looking around. Are there things in the way that we could trip over? Are there things that if the patient is able to get up that they would trip over? What's the environment look like? Visually, what are they looking? I many times walk in patient's room on day shift, the curtains are closed, it's dark in there, and some patients want it that way, but some patients, we need to open the drapes, it's day, so they know that it's daytime and not nighttime. So, you know, that's part of our job as well. Ask the patients, they may not get up. So what do we perceive? What is the patient perceiving of us? You know, our nonverbals, and we're going to talk more about that. Okay, kinesthetic is touch. And obviously, in this case, we have a patient who is comatose. Touch is going to be really important because if you touch them, you're going to be close to them when you're talking to them as well, right? And your touch is communicating something to the patient. All right, are there any distractors in this scenario? What would you consider a distractor when we look at it? All the drainage devices. Why is that a distractor from communication?
Because you're focusing on that instead of the person.
Okay,
that's behind
if you're
it.
just going in to empty it and you don't talk to the patient and we do those things. Okay, so drainage stuff, what else is a distractor in here? The alarms on the monitor, that's a good one.
The place, ICU.
The place
Exactly.
is in intensive care, okay? But think about communication. What's gonna distract us from communicating with our patient? What? He's in a coma? He's probably on a ventilator, which is, there's a tube down his throat. That tube, that thing makes noise, because it breathes for you. That makes noise, okay? So we have to think about that. What's the lighting like? Is there, does somebody just have the television on? What's the television for? He's a comatose patient, right? We don't think about those things, so I'm just trying to get you to think about that. So here's some goals that we want to try to achieve when we're talking about therapeutic communication. Now, guys, on my PowerPoints, I've already read the chapters, the stuff that I've given you. I pulled out what's important. That's my PowerPoints. So that's what you need to know. So if you're reading the whole chapter and you're reading something and say, she didn't cover that, it's not in the PowerPoint. I didn't feel that that was important that you needed to know right now. So my PowerPoints are where you want to study from. So what are some goals of therapeutic communication? Establish a therapeutic relationship. And we're going to talk about a nurse-patient relationship as we go on. Identify our patient's most important concerns. Sometimes we're so concerned about giving the patient medication or getting our assessment done, and our patient is really trying to tell us something else. So what's most important when we walk in? What is the patient perceiving when I walk in? I had a nurse one time, I had to stay, I was having some heart issues, and the night nurse came on. The night nurse's perfume, powder, whatever, came in the room before she did. And when she left, it stayed. You don't need to be all made up and smell nice for night shift. We don't care, we want to go to sleep, okay? So that's a perception on my part as the patient. It didn't make me want you to be my nurse more because of that. It bothered me, it actually bothered my stomach. So we gotta think about those things. Facilitate the patient's expression of emotions. Sometimes patients can't get out what they're trying to say, and we need to investigate that and find out what are they trying to say to me. And we can find that out by asking yes/no questions to get to the bottom of it. So teach the patient family necessary self-care skills. Okay, so what is necessary for me to get done? Because if the patient can do it, the patient needs to do it, not me. Right? Or a family can be taught and they can do it. Recognize the patient's needs and implement those. Guide the patient toward acceptable solutions. So when we look at this right here, these are the goals. Do you see any pattern?
Oh, there it is. Turned off for a hot second.
Okay. So what, do you see anything that's alike? What's a common denominator here? It's all patient-centered. We don't go to work for ourselves. We go to work for the patients. We become their advocates in what they need. And we become investigators and detectives. And we do that through therapeutic communication, through our assessment skills, and they're all patient-focused. So keep that in mind. You guys will do this at clinical. You'll gather all your information about your patient, And most of the time you gravitate towards the medical diagnosis, which they have COPD or they have seizures or they have diabetes. We gravitate towards that, and when we go in and do our assessment, we find out something different, but so we have to go that direction. Or we go in and the patient says, you know, they usually ask the patient, now, what's your goal for the day? A lot of them will say, I want to go home. And so we have to work towards that. But if there's something else going on, like the patient's complaining of pain somewhere else, and it doesn't have reference to the medical diagnosis, I need to take care of that, right? I don't want my patient to be in pain just because, well, we'll wait till we get your diabetic medication, and then we'll see how it is. No, there's an issue then, so we want to do that. Okay, so we have the process of communication. We have verbal and we have nonverbal. And verbally, it's my spoken word to you, but it's also my written word. So your documentation and your verbal talking to a patient is one form of communication. The other form is nonverbal. And nonverbal, you got to get this, because if a patient's saying something and their nonverbals don't match up to what they're saying, which one do I believe? The nonverbal or the verbal? Nonverbal. That's what we believe. So if the patient says their pain is at a 3, but you see them grimacing and they're groaning when they get up, more than likely it might be higher than that. So I've got to go with the nonverbals over the verbals. That's really important. So some of the nonverbals are touch, which we talked about, and there are different forms of touch, right? So in the hospital, we're not going to use any kind of sexual touch, anything like that. It's a touch where we hold their hand, we might rub their back depending upon what's going on, but even giving a back massage is nonverbal touch because you're helping them to either relax or get rid of some pain. You're increasing blood flow. So you're doing things that are therapeutic. We want therapeutic touch when we're talking about nonverbals. Eye contact. That's where I was talking about when the nurse goes in and we go immediately to the computer and we just start clicking away at the computer. We've never looked at our patient. We've never gotten eye contact back from them. It's really important. With these masks that we've had to wear, what's one of the deterrents when we wear a mask? Can I tell?
If you're smiling.
It's hard to see if I'm smiling, isn't it? It's hard to tell those nonverbals. But in my eyes, you can tell. If you look and get good at it, you can see if somebody's sad in their eyes or they're happy. You can see if they maintain eye contact with you, okay? If they're in pain. Eyes can tell you a lot without anything else. So we've got to do eye contact. Facial expressions. Facial expressions can go both ways because to me, I know why I'm doing it, but the person who's looking at it might not get the same message. So you have to be careful of our facial expressions, and sometimes, we laugh when they don't want us to be laughing. The other is, if you don't know what your facial expressions are saying, stand in front of a mirror and have a conversation. And you'll see some of you don't smile when you talk. Some of you, you don't look at the person. So you don't know what your facial expressions are. I don't even know how many years it's been, but I started one of my jobs at Marion General and I started a nurse aid course. I did 2 weeks of orientation with the nurse aides that came into the hospital. Created the whole program, put it together, and at the end I would always take a survey. Please be honest with me. You're not going to hurt my feelings. If you didn't like my hair, put it on there. I kind of joke with them, but I wanted them to be honest with me. They were. And one of the students told me, they said, the very first day that you walked into class, we thought you were the instructor from hell. And I had to look at that and go, okay, what were they seeing that I didn't want to project? Okay? But I thought back, and many times my mind was on, okay, I'm going to get my stuff together, and I didn't communicate with the students right off the bat, and that's what they took from it. So I'm always very conscientious of when I meet somebody the first time, a class like this, you know, that I am try to be warm, smile, because that's the first impression that you get. And then it's hard to change that. So think about your facial expressions. What do you give off to other people? Because that's what patients will be seeing of you. Do you smile at them? Do you have a happy demeanor? Or just you really don't want to be working today? You know, those kind of things. Okay, what else do we have? Our posture. Posture are things like when you stand by the patient's bedside and you talk to them, what are you doing with your hands? Okay, for patients, for people who don't know us, especially working mental health, you want them to see your hands. Don't put them in your pockets. Don't put them behind your back, because some patients feel like that you might have something. You know, they can create things, especially if they're paranoid. So just think about that, and don't do things like this, because that closes you off to communication to someone, okay? So you just want to, you know, use your stethoscope, put it back on, put your hands down at your side, or if you're, you know, on the computer, whatever, but make sure they can see your hands. And your posture, sometimes I go in and if I just want information and I'm not doing any assessment, like with my stethoscope and a thermometer and all that, I'll just sit down on the edge of the patient's bed if it's okay with them. Then I'm on their level, and I'm not standing over them. Because we do that all the time. We walk in and the patient's in a vulnerable position in a bed and we're standing over them. So just think about that. Go to the foot of the bed, talk to your patient, and then as it warms up, get closer to your patient. Okay? All right, gait. That's how you walk. And this is, you know, patients will pick up things with us, but we're also looking at things from them. You know, like, because if someone has a shuffling gait, it could be related to a medical diagnosis, or if their speech is slurred and they can't stand up straight and they're kind of, you know, woozy, there could be alcohol related. There could be something like that. We don't jump to conclusions, but we want things to be like, when you guys walk, we don't think anything, because you're just walking normal, all right? That's a nonverbal though. Gestures that we make, and I want to point out here, sometimes the gestures that we make in our American white culture are different than Asians, blacks, you know, other cultures. So be very careful about having little side jokes with you and another nurse or things like that, because patients don't understand, and then they might interpret it wrong. So you just have to be really plain and simple and easy when you're at work. Some sounds, there's numerous sounds, numerous meanings to sound. And we're going to talk about silence, because silence tells you something too. Okay, there's some other things on there. How do you appear, which is mode, dress, and grooming, which is what I was alluding to when the nurse had so much perfume on. It was gagged me. I mean, my stomach turned. So think about all those things when you're thinking about communication. So verbally, these are the things when you're talking to someone, especially a patient, especially a child, when you talk about it, have concrete messages. These things that I'm talking to you about work with members of your family as well. So if you're having trouble with a child who's not following through, maybe you're giving them abstract messages, or you're giving them too many messages. Like my son, if I would have told him 3 things to do, he might have done 1. So I figured out I can give him 1 and do it, and then give him the next one. because he just wouldn't follow through. It was too, his mind was go off on something else. So you gotta be very concrete, you know, if you want them to clean up their room. Don't just say clean up their room, clean up your room. I want your room cleaned up today. I would say your room needs to be cleaned up with nothing on the floor, your bed made, and your desk straightened up by 4 o'clock this afternoon. That's concrete.
And nothing under the bed.
And nothing under the bed. Okay, yeah, or shoved in the closet, right? Because I'm checking. See, that's concrete. So like if you want a patient, I want you to take 2 walks today by 3 p.m. to the end of the hall and back. You gotta be concrete, not just I want you to get up and take a walk today, and when you ask the patient if they did, well, how far did you go? To the bathroom. See? So that's not, it would have been abstract by saying that. So we gotta be concrete. Some of the techniques that we use when you're verbally talking with someone, and you'll want to look these up because I won't go into detail with each one of these. But when you want to explore, there's a certain way that you're going to ask questions to patients or to whomever. You're going to explore and ask other questions. Sometimes you got to focus them because you know some patients will just talk and talk and talk and talk, and it's like, I don't want to document all that. What was it that you gotta, okay, wait a minute, I just need to know about this right here, okay, and focus them on a particular subject or topic that you're talking about. That way you'll know what to chart, and you won't have to figure out from the whole conversation that one thing you needed. Okay, so sometimes you have to focus, sometimes you have to restate. So a patient tells you something and you want to make sure that you got it, you restate back to them. So what you're telling me is, and then you say it, and then they say, no, that's not what I meant. Okay, then I didn't get it. That's why we restated. Or you can reflect, go back and pick up different feelings, or go more in depth with that. So make sure you look those up in your book and know how to use those. So when we look at this, nonverbal, here's body language. Is this one over here open or closed?
Almost looks like he's pushing away. Like, don't come close to me.
So you think that one's closed?
Open.
And what else rest of you think? Open or closed?
Open.
Because
They're facing each
they're facing each other, okay? Hands, okay. Yeah, you interpreted it that they were like away, but they're facing each other and they're on the same level, aren't they? Okay, so they're just having a conversation. So that makes this one closed. Why is that closed? His eyes are closed. But look at his body mechanics non-verbally. Why is that a closed thing? He's comfortable. He's got Snoopy right beside him, and who else can get in there? That's closed. That's a closed thing. Like, I'm relaxed. I'm comfortable. I can sleep. I've got my thumb. It's good. The dog's here. We're fine. So you have different body language that you give off, like standing over the patient, sitting next to them, pull up a chair and sit next to them. Doing different things like that to not, in certain situations you do want to have a closed, okay? When you go to the bedroom with a partner, that's a closed place, right? Okay, we don't want it to be open. So there are times when you want it to be open, sometimes when you want it to be closed. So that's just a way to show nonverbals, is why I put that in there. So our nonverbal communication skills, facial expression, I talked about that. You know, is your facial expression expressive, impassive, confusing? You know, because you're kind of wrinkling your brow, and I don't really know what you're trying to say to me, and it looks like you're mad. So that facial expression says a lot. Body language, open and closed. vocal cues. Okay, so vocally, are you trying to get a person to go one way or the other? What cues are you giving off vocally? Are you loud? Are you soft? You know, in the situation, does it match? Does your communication match with this situation? When we talk about silence, I want to talk about that just a little bit because silence does tell us something. Sometimes when people are silent and they don't tell you anything, what can that mean? It can mean they don't know an answer, so they're quiet about it. It might mean that they're a quiet person. Okay, they are okay with being by themselves. They are okay with not having a lot of noise. Some people like that noise, right? Like, you know, I had 2 kids. When they were little, there was a lot of chaos, a lot of noise, and you kind of have to deal with that. But there were times when, okay, it's nap time, we get quiet. And then when it's routine for bedtime, we do the routine, we get ready, we quiet down, we get ready for bed. Okay, so silence, and then when a patient is just silent with you, can they understand you? Do they not understand? Why are they silent? You have to ask yourself, why are they being quiet? And is it good or is it maybe not good in this situation? Are they scared? Sometimes with kids when you do pediatrics, they're quiet because they're kind of scared of you. You're a big person and they don't know you. And mommy's always said, don't talk to strangers, you know, and I don't feel good, so leave me alone. There is a point when silence, we have to figure it out. So let me throw out this little scenario. So if you had, so we can really understand nonverbals, you had a fight with your spouse or significant other or a child, whoever in your life. You have an argument with them. When you leave the argument, it's not resolved, you both are mad, and you walk off. Okay? Let's take that same conversation because when we fight with somebody, well, let's talk about that. When we fight with somebody, what usually happens? What's my voice like?
Louder.
Louder. I usually get louder because I want you to listen to what I'm saying, right? So both of us are getting loud at each other. What else happens?
There's probably some anger.
Some anger, and how would that be manifested? How would I see the anger?
Veins popping.
Veins popping on their head. What's that?
Eyes getting bigger.
Eyes getting bigger, okay, yeah, like that, getting in their face. That's the other thing, getting in their personal space. There may be some hitting. I mean, that's potential. But if we're just having a verbal confrontation, it gets loud, veins pop out, we might get in their space, eye contact, like, you know, listen to me. Okay, so think of that. If we flip that, and you both now are blindfolded, and you're angry at each other. How does that go? Because I can't see any of your nonverbals.
You had to get off.
So I can only hear, can't I? So I could hear the anger in your voice, could hear you getting louder. But if I cannot see it, I just wonder if it's not resolved rather quickly. Because I can't get in your space, I don't know where you're at. All right? So nonverbals can be very calming to a communication. Okay? I'm going to maintain eye contact with you, but I'm not going to just raise my voice and get mad. Okay? So there's 2 different ways to look at the same conversation if we take away the nonverbals. So I need somebody just to read this for me. Who would do that? You? Well, you raised your hand, didn't you? No, see, that wasn't the nonverbal, was it? So just read it for me.
Mr. Ducks, Mr. Knott, Osar, CM Waynes, Lib, Mr. Ducks.
Now, what does that mean? Anybody got an idea? if you don't know what it is. Do you know what it is? Okay, don't do it. Or I'll let you read it. Does it mean anything to you? Okay, say it.
It's better if it's looking at country accent.
That's right, do it.
MR Ducks, MR not, OSAR, CM Wings, LIB, MR Ducks.
Okay, so you see what she did was, there's actually a store, I don't know where it is, have you been there?
No, my dad has a shirt of that.
And I've had students, they've gone there and brought stuff back to me because I've used this in class. So the point being, see what she did was, she put an accent in there, and we have patients and people who have different accents, come from different places. Also, the tone, the cadence of her voice. So, MR Ducks, MR not, OSAR, CM Wings, LIB, the MR Ducks. See, so you get a cadence going on, like when you're country like that, and you've got a twang in it, and then it makes sense. But if you can't pick up what they're saying, then it doesn't mean anything, does it? So sometimes it's the tone of your voice, the inflection that you're putting into it, the how fast or slow you're talking, because who likes a monotone teacher, right? So if I just stood up here, stood at the podium, and just talked and read my slides, you guys would be really, that's not a very good teacher. And you would all probably be sleeping. So it's my job to get you engaged in what we're doing so that you'll remember things and that you will be, happy to study. Maybe not, okay? So think about that. There isn't any magic words that you're gonna say to a patient always that's gonna work, because you have to take into account the patient, the situation, and everything. And how fast or how slow you talk might matter if they can understand you or not. Or if you have some kind of an accent and they can't get it. Then we have to change how we talk to them so that we can be therapeutic with them. So, congruence of verbal and nonverbal. Make sure what you're saying, how your face looks, is what you're trying to project verbally. If it doesn't, you've got to get those to match up. That's our job. Patients that may not happen with, but then if they aren't matched up, more than likely you better go with the nonverbal. And you can see they tried to put the facial expressions on there of what it might look like, what excited looks like. You know, some of us will never get that excited. But that's an expression. It's just some of us, the way we grew up, that's not how excited you get. So they may look like that, but their excited might look like happy, because they're just not going to get that excited. There are some people like that, you know. So we have to interpret that. So make sure they're congruent. So here's some levels of communication. There's 4 different levels that the book talks about. And it starts with 1, and then you just keep adding another person to these. So when you look at intrapersonal, that's me, just me. What do you guys say to yourself? What's your self-talk? When you're taking the test yesterday and you didn't know one of the questions, what do you say to yourself? What do you say to yourself when you look in front of the mirror? Okay, that's self-talk. And is it positive? Because many of us tend to see the flaws in ourselves rather than the positives of how good we dress, how good we look, those kind of things. So what's your self-talk? We want it to be positive. Then you add another person, and that becomes interpersonal, not intra. Interpersonal, because now I'm having a conversation with someone else. And we exchange information. Then you add another person, and now we've got 3. That's considered a group. And in a group, you can do things like well, they could be things like a teaching session, could be a staff meeting, 3 people, and it could be more than 3 people, but at least 3 people to have a group. Think about support groups, like AA, NA, Overeaters Anonymous. Those are support groups. So that would fall into this category. And then organizational, that's where you have, obviously you're gonna have several people in this meeting, and it's going to include, higher ups, people who do the job, but it's just considered a lot of people doing strategic planning, things like that. So you start with one, add another, and then you have several. And I just put that, I found that when I was looking for something to put in here as a picture, and this is all self-talk. What can you say to yourself? Instead of saying, I'm not good at this, look at it and say, well, what am I missing? What would make me good or better? And we tend to look at the things on this side. I can't do it. I made a mistake. It's not good enough. We tend to go there, and we should be on the other side when we do our self-talk. So here's a question. Effective communication with patients and family is based on what? Which answer? Don't answer. I'll say 1, 2, 3 answer, and then put up your answer 1, 2, 3, 4, whatever. Ready? Put up your answer. Everybody.
3.
Everybody's not participating. But the majority have 3. I don't see anybody who doesn't have 3. The answer is 3, okay? When we look at the other answers, just for testing purposes and try to help you, discussing topics that patient feels comfortable talking about. Why is that one not correct? Put your mask down.
I say because you might have to make them uncomfortable sometimes in home conversation.
You might have to make them uncomfortable, okay? What's the question asking? Effective. Effective communication is not, sometimes we do have to do that, but discussing topics that the patient feels comfortable talking about, that's where you are going, because sometimes things aren't comfortable. 2, using silence to avoid unpleasant or difficult topics. Well, we don't use silence to avoid. We can use silence, but we don't use it to avoid. And requiring the patient to ask for feedback. Sometimes patients just aren't going to do that. They might give you nonverbal feedback, but they might not give you verbal feedback. Okay, good job. So in your book, it had a table like this, and I just wanted to put in here your clinical groups. I know you haven't had clinical yet, which is good, because when we talk about this, we want to be down the middle column. You want to have an effective clinical. So what kind of, is a clinical group interpersonal, a group, or organization? It's a group. We call it that, clinical group, all right? So it's a group. And so when we look at the group and down the left side, variable. So look at group identity. What will make an effective clinical group? If you identify that you are a group, okay? You own the clearly articulated aims of the group. Everybody does. If it's ineffective, this is what you might see. There are aims that are not important to the group. Okay, so things that you're trying to get at, some people don't think it's important. Well, that's not a group then. It's not an effective group. When you look at cohesiveness, which gets to communication and things like that, what do we want? You want to trust each other in your clinical group, don't you? I hope you do. And you want to have a degree of cooperation, because if you're taking care of a patient that needs turned and you can't do it by yourself, you want to be able to go get one of your classmates in your clinical group and say, hey, could you come help me turn this patient? Cooperation. If you're not effective, it looks like there's people who feel like they're alienated. So when you guys get in your clinical groups, because I've seen this, and it's not necessarily the job of the clinical instructor. You guys make that group effective by making sure everybody feels part of the group. If somebody's hanging out there because maybe they're quiet, maybe they're just very nervous, and you only talk with if you have 8 in a group and 6 of you are like, you're all about it, but you got these other 2 who go off and they're by themselves. That is not an effective group because you're leaving someone out, which is that point. Low commitment, they work alone rather than the group. So if the group tries to pull you in and you're the one hanging out there, they're trying to help you. So whatever your reason is for hanging out there, you need to be a part of the group so that you can feel a part of an effective clinical group. When you look at interacting, when you talk with each other, what do we want to see? You want direct communication, you want honest communication, which is then where the trust comes from. So you want to tell each other they're doing a good job or not. You can tell it in a correct way. If you look at being ineffective with interaction, it would look like they don't self-disclose. They just, when you're having post-conference, they're the ones that never talk. And usually a clinical instructor will try to pull that out. But don't be like that. Try to get in with the group. You will feel better and you'll feel like you're part of something and you'll learn more. You actually will learn more if you become part of the group rather than hang out. Okay? Decision making. Okay? You go, how in the world are we going to get this patient from the bed to the Hoyer lift in this tiny little room that I can hardly get the Hoyer lift in here? You have to problem solve. And if one person is always the one problem solving, everybody else, you're not learning. So say, wait a minute, let me try to figure this one out. I want to try to figure this one out, okay? Or if it's the test question, say, don't answer it. Let me try to answer it, and let me tell you why I answered it that way. You're going to learn better and be effective with communication if you put some of these things to use. Responsibility. If you all are looking to the same outcome, that the patient stays safe while you're at clinical, that you got your assessments finished and you got your meds passed, and you look at those outcomes, which is why you went to clinical. I learned something today. I hope to learn something every time I go to clinical. Your responsibility is very strong and very high. You'll be more effective than if you don't take responsibility and you don't want to see good outcomes, or you only want to see it on your patient. Okay? Leadership, some people are leaders, some are not, but you'll have to be a leader when you're by yourself taking care of your patient. Because if you leave everything to the patient and give them the choice all the time, you'll never get anything done. Do you want to take your bath now? No. Do you want me to get your meds? No, I don't want my meds. Okay, see, you're being driven by what the patient's telling you. You got to take leadership. We're going to take your bath now, and then after your bath, I'm going to come back and give you medications. Okay? You got to be a leader in that, and that is an effective way to handle things. And then power. Power sources, you got to identify. There's going to be people who are stronger. There's people who are stronger in this room right now, maybe because of experience. You're going to be stronger. And so somebody who's never, we usually have students who've never been at clinical, you've never been in a nursing home setting, you've never been in a hospital, and you are scared to death to walk into that patient's room. Now you know how to do your assessment, but you're scared to walk in there. And what do I say? And you're just a nervous wreck. Some of you that are already somewhat adept at that because you've taken care of people, you work as a PCA, bring those people along with you. You started somewhere, so bring those people along to say, well, would you like me to go in with you the first time? Or come in with me and see how I do it. Work together and it'll be better than having levels of power if you use the power to help everybody come along. okay? That's effective. And that's gonna help with communication. Oops, I hit it again, no, okay. So, some more effective communication. Dispositional traits. I'm gonna see if I can get this up and show this little video to you. I'm not sure if it'll work, but we're gonna try. I always get messed up with the sound though, so that's the thing. There we go. All right, let's see, let me shut me off. Let's see if you get sound. You good?
So what is empathy, and why is it very different than sympathy? Empathy fuels connection, sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy was relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person, or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I have it, yeah. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. At least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
So that's empathy. Wasn't that good? I like that. I like that a lot. So to have effective communication, we want to have empathy. I've thought about this one a lot, especially when I go to funerals, viewings. And if you're the one who's suffering the loss, what is it that you want to hear?
I'm sorry for your loss.
Right, most of the time it's just, I'm sorry for your loss. I don't want to hear about your loss. I don't want to hear about, well, at least you have this. See how different it is if you don't start that way, because then it's not focused on me, it's focused on you. I'm sorry for your loss. And end it there. That's it. Okay, so think about that when you're talking about patients. Remember, patients in the hospital, they don't feel good. They've just gotten a diagnosis, and maybe it's a diagnosis of something very life-threatening. Maybe it is cancer. Maybe it's, they see diabetes too as never going to be able to have a life. They don't see the big picture. Yeah.
So on the empathy and sympathy thing, I want this to be clear there. Like, how you said that when you go to a funeral and somebody
Mhm.
passes away, and there are a lot of people, they would just start by saying, I'm sorry, but then again, they would kind of change it and say that I have lost my mother or someone significant like as you did, and I know how that time was. I understand that they're connecting, but I feel like they're also making it to themselves.
That's right, that's right.
So that's not necessary, right?
Well, sympathy, I could have experienced a loss as well. So that's sympathy, but to be empathetic with somebody, we want to make it about them at that time, okay? We want to make it about them, not about ourselves. Because empathy means I got to really reach inside and feel something that I've never gone through. Like the example on there, I've never had a miscarriage. And if someone tells me that they did, I can't sympathize because I've never had it before. But I can empathize to say, I really don't know what that feels like. But I'm glad you shared it with me. Something like that, okay? So the focus is not on us when we're being empathetic. It's on them. All right? So some of the other things on here is being warm and friendly, obviously. And we can do that through touch. We can do that through facial expressions. We can do that through how we introduce ourselves to people. Be honest and authentic. Sometimes we don't want to be honest. And sometimes patients ask us questions that it's not our role to answer. We have to get the physician, and the physician needs to talk with the patient. But as nurses, we're seen as someone who can empathize with them. You know, if they get a cancer diagnosis, we're not going to sit there and explain all of what that cancer means. It would be better if we would be empathetic towards the patient, right? I really don't understand how you're feeling right now, but I'm glad that I'm here and I can share this with you. Something like that, because we make it about them. Okay? All right. Some more effective communication. So what's the object when we think about what we're going to do with our patient? So just to kind of make a scenario, so when we go in our patient's room, if it is, our object is, I've got to get a physical assessment. Okay? You're going in the room to get a physical assessment and get it done, head to toe. So that's our objective. And it could be anything else. It could be that you're going in to teach them something. It could be that you're going to go in and have a discussion with them. But just for us putting it into perspective, let's say we're going to go into our patient's room and do a head-to-toe assessment. So when we walk in, what do we do when we walk in? Introduce yourself. Ask their name, because you got to identify them, correct? Probably washed your hands, right? Yeah, we washed our hands. And start it with something like, good morning, hello, my name is, all right, so we start that way. So and we look in the environment. I'm going to do a physical assessment, so I want my patient to be comfortable, don't I? So part of that is introducing myself, telling them what I'm going to do. What does that mean when you're going to do a head-to-toe assessment? Okay, it means I'm going to listen to your lungs. I'm going to check your heart. I'm going to, feel for your pulse. Those are the things I'm going to do. And I'll tell you what I'm doing as I go along. If you sense that they're uncomfortable. So we make the environment very comfortable and very unhurried. Even though I know you should be able to eventually get your head-to-toe assessment done in about 5 to 10 minutes. Starting out now, no. But eventually you will. But you don't want to seem hurried to your patient, because a lot of times we do that. We want information and our patient wants to talk to us and we just get it and go. So sometimes they see that as a negative. So privacy and confidentiality. How do I maintain privacy with my patient? Doing an assessment. Close the door. Pull the curtain. If it's a private room, it's probably just closing the door, but you do have a curtain. Okay, privacy, confidentiality. What if there are 2 people in the room? They're not private rooms, they're semi-private. I don't like semi-private rooms anymore. That's why hospitals are going to more private rooms, but they don't have as much space then. So if you have, and this will not happen at nursing homes, you're gonna have 2 people in rooms. You're gonna have, even at Marion General, they still have semi-private rooms. They're working on not. So if you have 2 people in the room, how do you maintain confidentiality?
You just try to schedule your assessment if the other person's out.
You could, if you knew your other patient was gonna go for a test, but you may or may not be taking care of the other patient. So you might not know that. So you pulled the curtain to signal to the patient you were doing something. When I would do a head-to-toe assessment, then I'm probably not gonna talk about the patient. And I don't like it when the physicians come in, because they just talk to you and both of them can hear. I don't like that, but there isn't any way around that. The point being that if they trust us, I can't go out and say things about the other patient.
Kind of violates HIPAA, does it not?
It does, I feel it does, but they still have to do it. So, but remember that you guys signed a HIPAA, so you don't go out and say something about the other patient because you overheard it. Be really careful about that, okay? And now, if it's a life and death thing, something like that, you would have to. But if it's just information and we live in a small town, okay, we don't go and talk about that on the elevator ride down to lunch. Just be careful, because you signed that you would keep it confidential. So be careful of that. What is your patient versus your task focus? Yeah.
So if you go into a patient's room and you have, sorry, my voice.
It's okay.
If you have to tell them something, is it appropriate to ask the patient, is it okay if we talk about things with the curtain closed?
Mm-hmm.
Is it better to ask for permission?
Right. And also go on the opposite side of the bed and try to keep your voice down when you're talking with the patient. We try to do that as much as we can, but the patient has to know that there's another patient that could be listening.
Right.
Yeah. Most of the time, it's not a huge deal, but you will get patients that don't like that. They don't want what's going on with them to be known to anybody else, okay? And so we try to help them as much as possible. Patient versus task here is what I'm talking about is, if you go in, we're gonna do a head-to-toe assessment, you've got that in your mind. You're gonna do the head-to-toe assessment. I gotta get my head-to-toe assessment done. And my patient wants to talk to me, or my patient needs to go to the bathroom, and I don't pick up on it, okay? It's not about doing the task, the patient comes first, always. So if they have to use the restroom, well, let's take them to the restroom. If they need some pain medication, then let's get the pain medication. Let's do what the patient wants before we do tasks, okay? Always. Now, you still have to get the task done, but let's take care of our patients first, be focused on them. And then, what are you observing, okay? What are you looking for when you go in to do a head-to-toe assessment? Well, I need my patient in a certain position, right? Probably want the television off or silenced while I'm trying to do this, because you have to listen to lung sounds and heart sounds, and it's hard to do over a television. Also, your patient may be focused on the television and not follow directions that you want them to do. Hand grips, push and pulls and things like that you're gonna have them do. So you have to look for things that will help you to be able to get finished what you're doing. And the pacing. So we go in, and like I said, you can get your head to toe done maybe 5 to 10 minutes, but that's because you worked on it and you're good at it now. Don't let the patient try to set that, because sometimes patients, you need them to be quiet while you're listening to them, and they're just talking. Shh, could you just stop for a minute? I need to listen, and I need to do what I have to get finished here. So sometimes you have to tell your patients to stop, and you set the pace. and get done what you need to get done. Not that you're silencing them from, if they're trying to tell you something like this hurts or something like that, that's different. But they're just trying to have a conversation with you, tell you about what's on television, you know, that their family's coming to visit. Okay, let me finish what I need to do, and then we'll have that conversation. So you set the pace as much as possible. So some factors that influence communication. We'll take a break here in just a little bit. I start seeing yellow in your eyes, so I know you gotta go to the bathroom, right? All right, so some factors that influence our communication. Developmentally, can your patient comprehend what you're talking about? If they can't, you've got to drop it down to a lower level. And all of our written brochures and things are usually written at a 4th grade level. Some of them are written to an 8th grade level. And this is for adults, because we want to make sure that people can comprehend what we're talking about. So you developmentally may not be able to ask your patient to go urinate. You might have to say, I need you to pee in this cup. Okay, see what I mean? You have to use it and where they can comprehend it. What's their cognitive development level? May not be the age that they are either. When you go to Children's Hospital and rotate, you get patients that are adults, but they're only can think, you know, to a 4th grade level. So it's not always based upon on how big they are, their growth. Biological sex influences this, because we as women, believe it or not, talk different than men. We give a whole lot more detail than men do. You know, they say that we use 20,000 words a day. And men use, what was it? And men, I don't know what the number is for men, but they use about 1,000, and they're done when they come home from work. So we don't, did somebody need something? You need it in? Okay, it's okay. Somebody recognized it and they told me. So, you know, sometimes we can talk female to female differently than if I have a male patient. Okay? We just communicate differently. Then those are factors that influence our communication. You might stay in a patient's room longer if it's the same sex. Why is that?
Comfort level.
Yeah, we're comfortable. So, it's okay, you're not doing anything wrong, we just talk differently. So sometimes if it's a, you know, a female that's been raped, no way would a male go in and talk to her to get information. See, it makes a difference in certain situations. And those factors influence whether we get communication or not. Sociocultural, all of us have personal beliefs, we have cultural beliefs, we follow a religion or we follow a culture, and we traditionally do things. Sometimes there are prejudices, and that causes a barrier. So we cannot be prejudiced when we're working with patients, which we take an oath per se as nurses. We're going to care for patients. It doesn't say I'll care for patients that are white, or I'll care for patients that believe the same way I believe. No, it says that we'll take care of patients and we'll be safe with them. So we don't, if it's a drug addict that keeps coming back to the emergency room, we don't judge them, we take care of them. Okay? This is a profession of non-judgment. Non-judgment. Also try to, like I said before, try to use lay terminology, especially with cultures. They don't always understand everything, or hospitals now do have people, interpreters. So if you can't understand what your patient is trying to say, or vice versa, we can get interpreters at the hospital now. All right, and then your roles and responsibilities. So respect in this instance is going to get you a long way. Just respect that person you're taking care of. no matter what they've done, how they look, what they say. You know, I've worked mental health for years, and there were people who, you know, tried to bite, tried to spit on me, tried to hit, you know, get into a fight, all of that, and you can't judge that person because they tried to hurt me. I mean, there was an instance why they did that, so I can't judge them. So I should not, I gotta take my role and my responsibility seriously to help that person, in whatever way that is. Some more factors that influences space, because we talked about touch and how close are we gonna get to patients? What's our space and territory that we can get in? Some people are comfortable to get into other people's space. I've worked with a lot of people, a lot of patients, different people. I don't have a problem being in someone's personal space for the most part. If I said something, I won't get in someone's personal space. But our personal space is about as far as you can reach your arm out, because if I can reach my arm out there, a person is not going to hit me. So that's about 3 feet. And I've got it up there, what it means, okay? So you're going to use over here, public and social, more than likely. But sometimes we get into people's personal space when you're doing a head-to-toe assessment. You have to. And some people are uncomfortable with that. Some of you guys will be as you're doing your head-to-toe assessments in lab on each other. You're not going to be comfortable when somebody's in your personal space. But you have to know the situation, whether you're going to let them in your personal space or not, okay? So try to stay away from personal space, gain trust, and move in. So like I said, when we go in and we see our patient for the first time, it's probably not a good idea to just rush right in and get in their face, all right? So as you're walking in, you introduce yourself, you ask them who they are, you're getting close enough to, can I see your armband? But you don't just rush in and rush out and get in their personal space. We do it all the time, and think about the patient in the bed. They're in a vulnerable position. They can't run. They can't even get out of the bed fast enough for you to get into their personal space. So think about space and territory and where you can be. You can stay socially. That's not an acceptable space in the mental health arena, but we'll talk about that in a further course. And intimate, we never get to that. There are nurses who've gotten in bed with patients, and there are nurses who've gotten in bed with other staff and gotten in trouble. That is not a place for to have an intimate relationship in the hospital anywhere.
Guys, Grey's Anatomy is not real life.
Amen. Okay. All right, let's take a break till about 11:24. There we go. Okay, take a break. People are getting up on 90 to drink myself.